We are happy to welcome Dr. Lasse Lehtonen. I know he's holding some important posts. On the program, we only have the one which is relevant to our seminar theme today, and we invited him because he's a member of the EU Commission expert on effective ways of investing in health, if I have copied it correctly here, but I'm sure he can do some more introduction of himself if he feels like it. So Lasse, please tell us about securing access to healthcare in the European Union.
Okay, good afternoon everybody. I have a tough job of being the last speaker, and I'm very glad that so many of you came back after the coffee break. That's always a test for the last speaker, whether you are interesting enough. So basically I'm here as a member of the expert group in European Commission, and I will actually have three parts in my presentation. Firstly, I will briefly introduce the expert group, then I will open a little bit of the mandate of giving the opinion, the access to healthcare, and then finally going through some of the recommendations that we have made for the Commission concerning access to healthcare. So the expert panel of effective ways of investing in health is based on a Council conclusion from 2011. It was established in the midst of Euro crisis because it was well noticed that some of the Euro crisis countries, Greece most notably, had big difficulties of balancing their budget and keeping adequate healthcare ongoing at the same time. So basically this was a prioritization committee set by the Commission to look for how to affect the healthcare budget of the Euro crisis countries, for more or less. But as it happens, the Commission soon noticed that they could have use for the opinions for other purposes, and in real life this has been more like making policy papers for the Commission than looking the individual issues in the Euro crisis countries as it was the initial idea. So in the Commission decision of establishing this panel, the tasks are listed as follows. So we are to provide the Commission, upon its request, advice on effective ways of investing health, and we should take into consideration the work that the other European Union bodies have done. And actually the Commission very often asks the same question from different parties. Typically they have their own internal process ongoing. They will use some experts, and then they might have a consultancy grouping, so they will manage the issue from several viewpoints. I was a reporter for the cross-border cooperation recently, and it was very fun actually to look how the different sources of information were analyzing this issue. And as always, when you are an independent expert, the advice for Commission is non-binding. Still, I would say that the recommendations that we make in the policy papers will most likely appear in the suggestion for directives or regulations somewhere after 5 or 10 years. So the process of preparation of things is very slow in the European Union, but if you want to really influence on the thing, you have to do it very early on, because when the process is started and goes to the phase where the member states actually start to give their opinions, it's usually too late to actually have any impact on the final outcome of the resolution. So in a way, it's very interesting to be in the very early phase of the policy making preparation in the Commission. That's for me a new thing. So thus far we have had established, I think, 8 opinions. So started from the public-private partnership, that was a reporter there. Then we had a paper of assessing the effects of health reforms. Well, again, in the midst of the Euro crisis, I think the Commission needed something how to look what is happening in Ireland or Portugal or Greek or or Spain. And then we had opinion in how to strengthen primary care. This got big publicity. There was an editorial in Lancet last year, for example, on this. I was chairing the quality and safety opinion. Then we had a very interesting opinion on competition, which I think should be very useful to read when the Finnish healthcare reform is going on. Cross-border cooperation, I was again the rapporteur. Then this opinion, access to health services, this is in preliminary phase, and then we have another opinion out for public consultation on disruptive innovations at this phase. So 4 or 5 opinions per year. And the panel is actually consisting of maximally 18 members. The Commission have appointed 12 members that are there, not representing their countries, but representing their personal expertise and field of expertise. So this is a multi-professional group of people. There are persons from health economics. I probably represent there, together with Dorian Marusic, the hospital sector, and also to some extent medical law, since I have background also in law. And then there are people from Jan de Meisner has been the chair of the primary care doctors in Europe and so on. I just bolded the persons that were involved in the working group for the access opinion, and for that working group we had also 2 outside experts making the opinion. So the panel works in a way that you usually name a working group, so we are working for 3 or 4 opinions at the same time. It means that there is no way that you could be in all of the meetings that are organized, so usually I personally try to be in 2 opinions at the same time about in the preparation, depending on their interest and the schedule, and then we invite a few outside experts for each of the opinions. And the Commission had a secretariat that is helping us for the data gathering, and usually the tasks come from the different parts of the Commission. For example, the competition opinion was actually asked not by the Sanko but for the competition department of the Commission. So what is the background for the access opinion? Basically, we know, and the data what I'm presenting here comes from the Union sources, so this is mainly Eurosilk data, that there are about 18 million people in European Union 2 years ago that did not have access, according to their own report, to adequate healthcare. So this data, this is partly gathered from the member states, but very much it's based on the surveys that the Commission is carrying out. And what is actually important here is that the people that did not have access to healthcare was decreasing up to 2009 and has been increasing after that. So the Euro crisis has definitely have an impact how people have access in healthcare in Europe. And this is, of course, mostly seen in the Euro crisis countries. And when we are evaluating the healthcare system, so looking to European health policies, the starting point is that European Union has some common values how the healthcare should work. So it's based on universality. Everybody should have access to good quality healthcare. The healthcare system should be equitable, and there is a solidarity element involved in the financing of the healthcare sector. So these are the basic values that the European healthcare is based on. And I think even between member states there is very little dispute on these common values. When we are discussing of the access, then I just want to point out, and this is also referring to the discussion of the patient choice, that there are of course patient preferences. So some people like one doctor on one treatment, and that's part of the patient empowerment that we leave some of the choices for the patients. But when we are analyzing access, this of course means that we should analyze the possibilities to have access to healthcare and not how they are practically used. Of course, the practical use might indicate problems in the access, but basically, of course, the patients must have the possibility of make choices and refuse treatment or select a treatment that is perhaps medically speaking not the best one if they want. That's part of our democratic society that is based on the self-determination of its subjects. And access as a concept is a multidimensional issue. So there are problems in the access on individual level. So if you have difficulties in moving, for example, you have a impairment, you have problems in access on the basis of your personal properties. But then we have issues in health by the health service providers. For example, if you have a insurance-based system, so if you don't have the insurance, the provider is not accepting you when you are needing. And then on the system level, whether it's having universal coverage or not. But much of the coverage is actually affected by the social policy issues, not by the health system as such, because in the end of the day, it's all question of money. So how the money is distributed, whether people are working, whether they have income, whether they have adequate education so they can use the services, whether we have transport systems, how the regional development policy is working, and so on and so on. So of course, health systems are part of the society, and all aspects of society are having some impact on health and healthcare. So the expert panel works on the basis of the mandates, and this mandate was given to the panel about 1 year ago. So the Commission was asking from the panel on its views to improve equity of access to health services in the European Union, and the mandate consisted of 4 specific tasks of analyzing the overall impact of poor access. I do not actually go to this in detail because the primary preliminary opinion is something like 160, 170 pages long, but I try to pick up the policy issues that have most relevance for this panel. Then there was questions about how to measure the access and monitor the access. Then also we were asked, are there limits for acceptable variation? So what type of differences can be allowed between socioeconomic groups and so on, or between the member states? And finally, we were asked to give policy recommendations. What should Commission do to ensure the access to healthcare in its policies? And we gave the opinion out for public consultation 6 weeks ago. Usually these opinions, they have a public consultation period for 6 weeks. So this is still on preliminary state, and by the deadline for the consultation, so November 6th, so Friday last week, there were about 400 comments on the opinion. So this was very actively commented. Yeah, to be honest, some of the Finnish professors who are members in the professional societies in Europe also contacted me and actually gave some compliments. This is by all standards is a very good opinion, but was also noticed by the professionals. And well, the initial opinion idea was that there could be a final acceptance of this opinion in early December, but I would almost say that it is probably up to February, because there are so many comments on the opinion that it will take more than 4 weeks to implement them to the opinion. So after public consultation, the expert panel goes through all the comments and will implement some of the requests or changes to the opinion, and then accept the final opinion. So how did we start to look to access? And on the basis of the scientific, and I would recommend that the opinions are as much as they are evidence-based. So we gather a lot of scientific data, but in the end of the day, if there would be, for all of the issues, there would be valid data, then you don't need an opinion. You would know this from the literature. So these are always tough issues where you have to balance and have to have some ideas how to combine the different issues. So we analyzed this from the 9 viewpoints, starting that there are adequate financial resources, they are affordable, people can use the services when they need them, they are acceptable, also that they are relevant and cost effective, there are quality devices and medicines available, also staffing is appropriate, and the facilities are within the reach. So these 9 parts will then secure equitable access to health services if they are taken care of. Okay, and I will start from the financial resource issues. And as I said, it all depends on the money. So there is overwhelming evidence that if you don't have final resources in the country, of course, then you have also poor health and very unequal use of the services. And if you look at this from the cost efficiency point of view, this also leads to inefficiency, because the people that have money, they will use services that they don't need, and those that would have most of the health benefit of the services cannot afford this. And even we are in the rich part of the world in Europe, the income level is very decisive also in Europe when we look to the access of the services. This is from the Eurosirc data from 27 European countries, and if you really look the poorest quintile and the richest, you see that there is big difference. But when you look the distance or waiting time issues or whether the person self have time, there is much less difference how they impact on the access. So basically, still it's the income level that is very important in how people can access services in Europe. This is Europe. And what this means is, of course, that if you want to have equal access, you have to tax people and redistribute the people, what we are doing. So that is very simple thing. So the public spending is very important in guaranteeing equal access to healthcare, period. This is simple as that. And in the end of the day, then the level of spending results whether you have adequate access to healthcare. And in Europe, this varies from over less than 4% of the gross national product to over 10% in the Netherlands. And Finland, as you know, we are having almost 10% share from our gross national product. The healthcare share is about almost 10%. So what should European countries should actually have public funding for healthcare? This is very important, and this is most important when the economy is in crisis, because otherwise you will have more differences in the access to healthcare. And there was a lot of discussion where you can identify from the WHO data or some data that what would be the minimum level from the gross national product that countries should spend to healthcare, but that cannot be decided on the basis of the data. But if you, on the other hand, use a lot of your gross national product healthcare, then there is the problem that this also may drive prices up. So both salaries and prices of pharmaceuticals and devices, which is sometimes the case in the USA. So not only having enough money is sufficient, but you have to use the money wisely, and this is much more difficult thing. And then we come to bodies like our Finnish council, that somebody should give advice how to use the money wisely. I think, as we heard from the Norway, this is not a new invention. We are working in different countries to establish mechanisms how to use the money wisely. Then other issue there is that also within the country the money should be used in a way that it's meeting the regional health needs. There are always policy issues here. So you have different type of health problems in different countries and at different times. So you should look the data of the issues and look the spending and see that the money really goes to those areas that are issues in healthcare. And I will return to this issue later, but it's of course changes are sometimes very difficult to make, and if people have suffered, for example, cardiovascular diseases, and then you will have cancer as the main problem after 30 or 40 decades, it's very difficult to move the resources from one sector of healthcare to other, even though actually the health sector or the therapeutic area would have lost some of its importance. Okay, then the next issue after the adequate financial adequate funding is that the services are really affordable for everybody, and this is related to then the share of the out-of-pocket expenses in the healthcare cost, and usually the affordability issues rise in the countries where the public spending is low and or where there are real gaps in the scope of the coverage. So meaning that some disease areas or some services are not covered at all. Then people tend to start to take voluntary health insurances, and they are not usually very cost effective in securing the access to healthcare. That's also something where there is quite a lot of data. So if we look how the out-of-pocket payments are distributed within European countries, so in Finland the patients pay about 18% of the cost of the healthcare by themselves. But it's very funny to see that in that there is a big variation. So in some countries the out-of-pocket costs are about almost third of the cost, and in some countries some below 10% only. And I would repeat that to avoid the problems with access, again, the solution is that most of the money should come from the public spending, and it is advisable to keep the out-of-pocket payments pretty low. Also due to the fact that if the patient really cannot decide by themselves what is useful and what is not useful spending, and there is a tendency, if you have to pay out-of-pocket payments, that people make inappropriate choices and leave. For example, for the medication, they don't buy the medication that is necessary because they want to spare their money. But attention should be made then also that the cost-effective services are prioritized. So one part of making services affordable is that you have a system where you really, if you would charge from something, it's preferable to charge on services that are not cost effective, and you should support the services that are cost effective, so helping the patients to make the right choice when necessary. Okay, then third issue out of the 9 areas is that the well-equipped facilities should be within easy reach, and it's not just the geography, because the problem is that if you want to run, for example, a primary care center that is working appropriately, or a hospital, you need trained staff, you need all type of devices, you need laboratory, and so on, and it is rather expensive to have 7/24 service all the time, and in the real life, when you are starting to spare money, you start to centralize, which might lead to the fact that the facilities are not within easy reach. But again, if we look the European data and looking the primary health care, so what is the percentage of the people that have to travel more than 20 minutes to reach the primary care facility? So despite of the fact that Finland is geographically a big country and we have long distances, it's just 17% of the Finnish people that have to travel more than 20 minutes to reach the primary care doctor, when it's in many countries is over 30%. I would not put this as a goal, but despite of the fact that we are a big country, we have a lot of facilities. That's a fact. And how should then the access be guaranteed? There are 2 basic solutions. One is that, okay, you have a network, and I would repeat the ideas of the Finnish healthcare reform, where you would have a central hospital that is having a full service, and then perhaps some type of satellite hospitals that have a more limited service. So this is actually in accordance with the recommendation that the expert panel is also making. But the other way of solving this is to move patients and personnel. So of course, in a big country, sometimes more efficient to have a helicopter service to move patient from a remote location to a emergency department than to have emergency department by every lake and valley. Then the fourth issue is that how to secure that there are enough health workers with the right skills in the right place, and this is not a major problem, to be honest, in Finland, but in Europe we tend to have countries that are losing a lot of doctors to other countries due to the free movement of labor, and this is causing problems in countries like Lithuania, for example, and some other Eastern European countries where the doctors move to Germany and to countries where the salaries are high. And there are some countries like UK that has been relying for imported staff for a long time, and they are really not training adequate numbers of health professionals. And due to the fact that more and more people want to live in the cities, and we have problems getting doctors and nurses to rural areas, and we see that problem also in Finland. And what are the solutions? This is very simple in a way. Of course, you have to train adequate numbers of people, looking also which are the areas, for example, in the medical training where you are lacking specialists, but also that you have to have appropriate working conditions in the areas where it's otherwise difficult to keep the staff. The skill mix is a problematic issue because it is sometimes very difficult to change the division of work between the different professions due to the fact that it also have implications to the salaries and other financial incentives. And then how to guarantee the access to quality medicine and medical devices. And during the past years, the prices of pharmaceuticals have been rising much faster than the gross national product. So the share of the drug budget from the national budget and hospital budget is increasing all the time. And we are starting to face problems in Europe of securing access to medicines. The hepatitis C drug case has been widely reported in the press and discussed by the professionals. So this is a problem also in the world, Europe at the moment. And if we are looking at the expenditure for pharmaceuticals related to purchase power parity, we see that there are big differences. So, for example, the Germans use over 2 times more pharmaceuticals in relation to the purchasing power than the Danes, and we use about 50% more than the Danes, but about the same as the Swedes. So there are big national differences how much money are used on the pharmaceuticals, but to my knowledge there is not a major difference in the health outcomes between Denmark and Germany. So there are something that should be looked at why this is the case. And if you look the device part, we have countries like Finland where you have a lot of, for example, magnetic resonance units per capita available, and still you have rather long waiting times to the services. So there are definitely some inefficiencies how the resources are used. So what to do? One issue is that there should be some novel pricing mechanism. At the moment, the pricing is set on the basis of the value of the drug to the market, and when you have patent rights you don't have any competition, and actually the patent policies in the European Union has been such that you have been prolonging the patient period all the time, which is actually then preventing competition. So the pricing mechanism should be discussed, and I very much agree with the previous speaker that the transparency is an issue here, not really that you would start to make secret bargains behind the closed doors. But then one part of this is also the health technology assessment. We should use it more when launching pharmaceuticals. I know that the Finnish Medical Agency is doing this, but actually we would need much faster and wider use of health technology assessment in the launching phase of new pharmaceuticals. And the other part of this is that we should also make wise algorithms how and which patient groups would actually use the devices and drugs. So there should be more thought to put for this in the healthcare system, and not just only follow the recommendations that you get from the industry. Then how then to secure that people are able to use the services when they need it? There we have some issues. First of all, in the end of the day, people really don't know. There is always the lack of information, but sometimes actually there is too much information, because if you are Googling in the internet and trying to find the services, you would actually enter to totally wrong place and may overuse the services as well. The health literacy is an issue, and I would claim that a big part of the population is not able to appropriately use the information that they have available. There is little data how to improve health literacy. No good studies how to do it at the moment. However, we know that health literacy also have a clear-cut socioeconomic gradient, so that people who have better income usually have better education, and they are able to make the choices. And the people that have less education and less income are less able to make the choices. So also when introducing the choice to the system, we have to be very careful that we are not increasing the inequalities in the system. Then the patient, of course, may face waiting times, so they are not getting the service within the time they would like to have it, and putting legal limits for the waiting times is a two-edged sword. It's sometimes leading to inappropriate prioritization, meaning that you get the service for something that you could actually wait for, and then the people who would urgently need the service do not get it in time. But in the end of the day, the data on waiting times give some information how the health system is working in general. So the expert group is not just suggesting that every member state should have a mandatory waiting time limit, but we think it's useful to monitor the waiting times in any case. Then, are the services acceptable to everyone? And Finland, for example, has been a pretty homogeneous country, and we are one of the few countries where the indigenous people actually have about the same life expectancy as the general population. So Finnish Roma, so Finnish Sami people are having same type of access to health services than all other citizens. But there are, of course, many countries within Europe where, for example, Roma people are excluded, and that's then increasing the inequalities and causing problems for the healthcare. But what is, of course, new that we should also follow the user experiences and try to improve the services that they would be more acceptable. And if we put this to the Finnish context, so how to make the health centers such that they would actually be seen better places than, for example, the private healthcare. At the moment, probably the view of the patients might be other way around. So the user experiences are very important when we are trying to make the services acceptable. We should be culturally sensitive. Also, the healthcare staff should have better communication skills. We should have a lot of information available from the digital world, and then the user surveys should be carried out in regular basis. So then finally, the services should be relevant and cost effective, and I would emphasize that even though the expert panel has the mandate of looking how the access to healthcare should be secured in the European Union, this does of course not mean that everything should be available for everybody at all times, because the resources are in any case limited, and it's therefore very important that the spending is cost effective, but not only cost effective but relevant to the health needs of the population. And I think this is something that should be discussed also when we are discussing of the prioritization. It's not only really whether a method or a device is cost effective in the treatment, but also discussing what is the priority of the health policy at a given moment, whether we should emphasize on the mental disorders or whether we should emphasize the prevention of cancer, or what are the main areas. And to do this, well, there should be a comprehensive strategy, mainly for the health workers, but also to public. Look that the coverage is adequate and corresponds to the health needs, avoid over-medicalization, and again use the health technology assessment to make cost-effective coverage decision with both new and existing technologies. One thing that I would like to emphasize here is that we very rarely actually discuss of delisting of the old technologies. We always discuss whether something new should be included, but very rarely we discuss whether something old should be skipped. And this is something that I would like to take place much more often also in Finland. So, finally, to conclude, access is a critical component of universal healthcare, health coverage, and all the countries in the European Union have a mandate to ensure equitable access to health services living in their countries. This does not mean that we should really have everything available to everybody at all times, but it means that we should address the unmet needs and ensure that the resources required are delivered in a relevant, appropriate, and in a cost-effective way and match to the health needs of the population. Thank you.
Hey, thank you very much. A little bit of a different angle, but yet an interesting and important one. So would anybody like to ask anything? Are we getting tired? Can I see a hand? Could I ask, well, sorry, if this is not fair maybe to you, Siv, but looking from a little bit of from the Norwegian angle, not being in the EU, but very closely following and implementing all the same things. How does this seem to you? Sorry, I'm now exploiting you because all the Finnish people have fallen asleep.
What I was wondering when I listened to your presentation, you said that all necessary needs should be met, but the definition of what is necessary need is interesting.
Yeah.
And that will differ, I think, from country to country, but also from year to year, as the possibilities to give medical care increases due to health services success.
I agree. Actually, we discussed quite a lot of that, and if you read the full report, there is a lot of material how to assess the need and what are the criteria of the need in this context. I didn't show it in my presentation. I'm sorry.
Okay, anything from the Finnish perspective? Oh, there is one. Good.
Okay, Pekka Anttila. So one question about the health technology assessment. So what do you think about, should everything be done on the national level by the national authorities, or should we more rely also on some international health technology assessments? Or?
So one part of the cross-border directive is actually that there is a network of health technology assessment in Europe, and since many of the, well actually most of the innovative drugs and devices are regulated on the European level and come to the common market, I think it's very difficult to keep this in national level, also due to the fact that leaves it open for the companies to price their products on a national basis, and then there is a tendency that the small countries have higher price level than the bigger countries, which also increases the inequalities. And there is a push for the common European purchasing mechanisms, for example, for the new drugs. I think there should be more common European evaluation for this, just to the fact that we are in the common market as well.
Yes, indeed, and maybe I should mention that I'm actually a member of the European Commission HTA network, which is a strategic network, which is aiming to increase the use of joint reports, joint assessments, so that not every country should do all the evaluations or assessments by themselves. And we have THL and FIMIA, Finnish Medical Agency from Finland, who are actually taking part in the scientific and operative joint work collaboration. So this is really important and hopefully help us to avoid duplication of work. But an interesting and current example are the new drugs for hepatitis C, which were mentioned also by Lasse. And already was it last year or earlier this year, there was we did a survey in the HTA network, and there had already been 10 assessments in Europe, in different European countries, and it was interesting that there were different conclusions reached in these different countries. But of course, this is an area where after that, even now a few more drugs have been introduced. And as I showed you earlier, our council actually has this issue on the agenda, and we are waiting for actually, I think Finnish Medical Agency already received the joint assessment of the newest drugs for hepatitis C. And now what we are planning to do, if God and other high authorities are willing and let us do, we are going to look at the financial aspects in the context of Finland. And then later on, hopefully in the spring, somewhere in the spring of 2016, Council should give some kind of a recommendation. And it's not only the Council, there's also another group led by the Ministry, by the Infectious Diseases Board, which is looking at this very issue. And so there has already been a lot of European collaboration, but some things cannot be very easily transferred from another country to another, and those are very often the cost effectiveness evaluations and other assessments of costs. Okay, more questions, please. If not, we thank you very much indeed, and we thank all the audience for active participation and very good discussions. It has been interesting.